as Ralph said, I'm going to do a talk on the management of acute sickle cell emergencies in adults, and I wouldn't be a haematologist without showing a blood film with the sickle cells there. And this is a picture of Hammersmith Hospital lit up in blue last year, like lots of the landmarks were on the anniversary of the NHS. Okay, so topics for discussion are just a little bit about the pathophysiology and epidemiology of sickle cell disease, and then a management of acute admissions. So this is the map of the estimated number of births of sickle cell anemia worldwide, and as you can see, obviously the much higher percentage of births within Africa because of migration. We also see a lot of sickle cell within Europe, South America, and North America as well. So the prevalence in the UK is about 12,000 to 15,000, and about 70% of patients with sickle cell disorders live in Greater London. And there are about 350 new births per annum, and we try and capture all of this on the National Haemoglobinopathy Registry. The median survival of sickle cell patients was, historically thought to be only 48, which is very sobering, really. And then it increased to around 58. But this paper from our colleagues at St Thomas's and Guy's in 2016 said that in the UK, on average, the median survival is around 67. And that was thought to be due to the specialist care that we have here, the MDT approach of working, and the formalised transition process. And generally speaking, hemoglobin SS and S beta naught thalassemia tend to have the more severe phenotypes, and hemoglobin SC and other phenotypes tend to be mild. So the pathogenesis of sickle cell disease, I think, is well known, but there's thought to potentially be sort of two overlapping subtypes. A subtype where they have lower hemoglobins, sort of higher hemolytic markers, and scavenging of nitric oxide, tend to have complications related to pulmonary hypertension, leg ulceration, priapism, and stroke. And the more classical subgroup, if you like, where they have sort of higher hemoglobins, rigid sickle cells in the deoxygenated state, causing vaso-occlusion, where predominantly you have more sort of pain crises, things like acute chest syndrome. But I say these often overlap. So when we talk about sickling disorders, there's homozygous sickle cell disease, but there's also the compound heterozygous, as I said. So hemoglobin SS, hemoglobin S beta naught thalassemia, which is where you're not producing beta chains, tend to be the severe phenotype. And then you have hemoglobin SC, then hemoglobin SD, SO Arab, various others, hemoglobin S beta plus thalassemia, which tend, not always, but tend to be milder. Sickle cell disease really is a multi-system disorder, and really can literally affect pretty much every organ in the body. And you have lots of acute complications, which are highlighted here in yellow, and lots of chronic complications, which are highlighted here in green. And I'm going to touch on, hopefully go through quite a few of the acute complications that you might see in the emergency setting. So there's various types of acute presentations, sequestration syndrome. So in adults, that's mainly hepatic, whereas in children you can see splenic sequestration as well. There's hemolytic crises, aplastic crises, patients get priapism, neurological problems, fever and sepsis due to them being hyposplenic, hepatobiliary complications because it's a hemolytic anemia, they're more likely to have gallstones and the complications related to that. But highlighted in bold are probably the ones that you'll see most often in the emergency setting, vaso-occlusive hypertensive crises and acute chest syndrome. When a patient comes in with pain, obviously, there will be red flag signs that they obviously need urgent assessment. So they would be if, they were in septic shock, hypotensive and tachycardic, if they had neurological signs or symptoms, if their oxygen saturations on air were low, or they have symptoms of signs of anemia where their hemoglobin was less than 50 grams per litre, or there'd been a fall of more than 30 grams per litre from baseline, or if they'd had prolonged priapism. So nice guidance. I mean, I didn't realise it was so long ago. I'd forgotten how long ago this was published. It was published in 2012. Produced guidance on managing acute painful episodes in hospital. These next couple of slides, one of my colleagues, Stephen Okoli, provided, so thank you very much. The pain is excruciating. And this was published, I think, in a nursing journal, and where patients were asked to describe the type of pain, their sickle pain when they're in acute crisis. It's unbearable, excruciating, stabbing, a pain I wouldn't want wish on my worst enemy, like being hit by a truck and getting run over. And it causes up to 95% of hospital admissions for sickle cell disease. A third of patients have some pain 95% of the time, and 14% of adult patients are in pain less than 5% of the time, which is very sobering. And actually, a lot of patients manage their pain at home. When we were able to pre-COVID, we used to have a day pain service where patients were able to come, have a couple of doses of analgesia just to get on top of the pain, and be able to go home and avoid an inpatient stay. But unfortunately, because of COVID not being able to, and the COVID pathways, we were not able to offer that service. We're still not able to offer that service, and I'm sure that's seen a spillage of patients sort of attending A&Es. As I say, the vast majority try and manage at home or use the day pain service, and then there's a small proportion that end up coming into hospital. Precipitants for a crisis include hypoxia, anaesthetic, infection, dehydration, alcohol, periods, cold, stress. All these things can precipitate a crisis. And when you're assessing a patient with a sickle crisis in A&E, obviously the history and examination is really important to look for any potential triggers. You do the routine bloods, and often I put it in red. I should have put reticulocyte count in red as well, but often they get missed in A&E. So the reticulocyte count is important because that gives you an idea of red cell turnover. Group and save is really important in case the patient deteriorates, it's good to have a group and save there so that we're able to cross-match blood, and it's also it's obviously blood cultures if they're febrile, and doing a hemoglobinectophoresis is also useful if they've had a recent transfusion or exchange within the last 3 months, because knowing what their sickle percentage is will give you some idea of so if the sickle percentage is low, then they're unlikely to run into severe problems related to their sickle. You do sort of a urine dip and MSU, like a septic screen, chest X-ray, an MPA for Priapism, and obviously a COVID swab. So the initial management is hydration. Obviously, IV is not always possible because of poor venous access, and sometimes we encourage oral hydration as much as possible. If they can't have IV hydration due to being unable to cannulate, then we can give it subcutaneously. Keeping the patient warm, making sure that the oxygen saturations are maintained. Patients often have individual analgesia protocols that should be followed, and not forgetting the adjuvants to the opioid analgesias such as the paracetamol and the NSAIDs, antiemetics and laxatives as necessary. Really important for them to have DVT prophylaxis if there's no contraindication, and incentive spirometry is very important, because often, especially if they're having pain in the chest, if they don't take deep enough breaths in, then the airways at the bases are not expanded properly, and that actually puts them at increased risk of chest syndrome, which I'll talk about later. And often patients don't come in with chest syndrome, they'll come in with a vaso-occlusive crisis and then develop a chest syndrome whilst an inpatient, and in my experience it's always out of hours and it's always in the middle of the night. And it's really important to obviously regularly review and monitor for their pain score and sedation. And if they're febrile and have raised inflammatory markers, you'd stop penicillin prophylaxis and give them first-line antibiotics based on your local protocol. And because people with painful crisis may go on to develop chest syndrome, it's really important to monitor oxygen saturations as well as their other vital signs. Obviously, the different opioids have different conversion rates, and at the moment, I know some of our patients don't believe us, but there is no subcut diamorphine, and so we're having to switch them all to morphine, which some are finding not particularly palatable at the moment. And this is from the standards for the clinical care of adults with sickle cell disease in the UK, which was published in 2018. So if a patient presents in acute pain, it should be considered a medical emergency. You obviously assess them, initiate adequate pain relief within 30 minutes, looking for precipitating problems and complications. You reassess the pain every 30 minutes and until adequate pain relief is achieved. We usually start off with subcut analgesia. If it's unresolving, then we do move on to a PCA, which stands for patient-controlled analgesia. We use subcut PCAs here, but I know other centres which we manage ourselves. But I know at other centres you rely on the anaesthetists to do your PCAs, and they're often be IV. And the other crucial thing is if you're sending someone home from A&E or ambulatory care unit, is to ensure they have adequate discharge planning, including analgesia to take home, and you let their parent team know. And certainly in the northwest London region sector, there is, although there may not be a haematologist on site 24/7, there are haematologists on call 24/7 available for advice and to come in and review patients as necessary. And I would just always alert them to any sickle patient that comes in. Chest syndrome is one of the other main complications that you'll see, and does have a significant mortality associated with it if left untreated. I think it's about 5% if mortality rate associated with it. And I've certainly been involved in a couple of SIs at another trust where it wasn't picked up early enough, and teams didn't escalate quickly enough to haematology. So that's why I just emphasise it's really important that if you have a sickle patient in the hospital, because I know out of hours it's usually the on-call medics who will see the patient first, is if you have a sickle patient, just to contact the haematologist just to run things by them. So the acute chest syndrome is a lung injury syndrome initiated by 3 major triggers, all related to vaso-occlusion by sickle cells. So you have infection, embolization of bone marrow fat, intravascular sequestration of red cells, and they all cause lung injury infarction. That causes ventilation perfusion mismatch and hypoxemia, which leads to increased deoxygenation of hemoglobin S, which causes VOR, polymerization of vaso-occlusion, so you just get a vicious cycle. And sometimes it's difficult to distinguish from a lower respiratory tract infection, as I alluded to before. It usually occurs during a painful crisis. Features raised inflammatory markers, fever, hypoxia. I mean, all these things you see in a chest infection. But usually the infiltrates on a chest X-ray and chest syndrome, usually bilateral, bibasal, start at the basis and then just go up if left untreated. And as I said, it's a common cause of death and needs prompt treatment. Other investigations to consider: if a patient comes in with chest pain and shortness of breath, has the patient had a PE? Patients with sickle cell are prothrombotic, so they are more at risk of pulmonary emboli. So a CTPA, obviously looking for underlying infections and doing an infective screen. So for a chest syndrome, as I say, usually it's bilateral chest signs and chest X-ray infiltrates. And what I've seen before is where people see the infiltrate. Patients had chest pain, they've gone down the cardiac route. They think the fluffy changes on the X-ray are due to pulmonary edema, and they give the patient furosemide. So that was one situation that I saw. And the key thing is measuring the oxygen saturations on air and doing a blood gas on air, and a level less than 92% or PO2 less than 9 is of concern. Give them broad spectrum antibiotics covering atypical organisms, obviously high flow oxygen, hydration, incentive spirometry, CPAP or BiPAP if necessary. Thromboprophylaxis is important, nebulized salbutamol if there's wheeze or history of asthma, and regular monitoring, regular discussion, early, letting the outreach team know the patient's there. And then I'll go on to talk about the sort of thresholds for exchange, but if the patient does need an exchange, we're very fortunate here at Imperial that we have automated red cell exchange available 24/7. But I know that's not the case in other units. So, I mean, I was a consultant at Hillingdon, and we were first on call out of hours. We had a situation where one of my sickle patients came in the middle of the night at Hillingdon. And the medical registrar phoned me and said, "Oh, I think he might be having a chest syndrome." And all I could think about, just my night flashed before my eyes. I thought, gosh, if he's not stable for transfer, I'm going to have to do a manual exchange, which will take all night. And I had a whole day of clinic the next day, which I couldn't get out of. So I just asked, is he stable for transfer? We went through the observations. He was stable for transfer. I rang my colleagues at Hammersmith, and he was blue lighted across. And exchanged, and I think that's the key. That's why you should always escalate early to the haematologist, because I know it's the general medical team that will be seeing the patient first, usually out of hours, in the district generals. The key things they'll want to know is what the blood gas on air is, obviously the other indices, and what the chest X-ray looks like, and if the patient's stable for transfer. If they're stable for transfer, and you get them across to the tertiary centre, because it's much better to do an automated red cell exchange rather than a manual exchange, because it will get the sickle level down quicker. Avoid diuretics unless there are signs of heart failure, and as I said before, the chest X-ray signs may mimic pulmonary edema. And it is very gratifying when you do a red cell exchange. The patients do, if the cause is a chest syndrome, they do get better quickly. If they don't get better quickly and they remain hypoxic, then you think, well, could they have had a PE? And then you do a CTPA. And if that's negative and they're not getting better, and other things to think about would be fat embolism if syndrome, which I'll talk a bit about later, if it's accompanied by bruising or confusion or renal hepatic dysfunction. But as I say, I'll talk about that in more detail later. And these are our thresholds at Imperial. So, you know, where we give a trial of CPAP, and you know, reality is we do a red cell exchange. If the PO2 is sort of less than 9, we would arrange a red cell exchange. And this is an X-ray. This is a normal X-ray, and this is someone with a chest syndrome. And as you can see why someone might think that's pulmonary edema. We're part of the team on behalf of the National Haemoglobinopathy Panel, collecting a real-time national survey data on all patients with suspected or confirmed COVID, and the NHP produced this little infogram after the first and second wave around sort of for patients around those who had suspected or confirmed COVID. Compared to the total sickle patients in the registry, it's about 555. And in the first wave, there were 5.5% deaths, in the second wave, 1%. And actually, 2/3 of our patients with COVID were managed at home, and most cases have been clinically mild, and very few children have been affected or required respiratory support, and none of them have died. And it was similar to what we've seen in among the general public, that those who did badly with COVID were older and had other health problems such as high blood pressure or heart disease. I think in the third wave, we sort of collected the data, and most admissions, I think, so far have been those in the unvaccinated group. So fat embolism syndrome is a triad of pulmonary distress, neurological symptoms, and a petechial rash, and it's pro-inflammatory and it's pro-thrombotic. And patients who usually have it, not always, have a milder phenotype, which means they're hardly ever in hospital, and they just come in very, very sick. It can be associated with parvovirus infection. It can have a raised ferritin, and the blood film often, because of the fat globules in the pulmonary peripheral circulation, causes oxidative damage. You can see nucleated red cells, and they may be thrombocytopenic. These are the features that you see on an MRI. They call it, what do they call it? Star, I've forgotten what they call it now. Starfield pattern, that's right. They call it the Starfield pattern. And multiple small non-confluent lesions in the periventricular white matter, which are bright on T2 sequences and dark in the other sequences. And they call it the Starfield pattern. And then on a CT, you get interlobular septal thickening, which they call sort of a crazy paving pattern. There's no lab-specific sort of diagnostic criteria for it, but you have to have a high index of suspicion. And so you think about it, as I said, if someone's had you come in very unwell, you think they've had a chest syndrome, you've exchanged them, they've not got better, you've done a CTP8 and they've not got, to exclude a PE, they've not got PE, they're coming thrombocytopenic, they've got oxidative changes on their blood film, raised inflammatory markers, raised ferritin, a relative reticulocytopenia because you get bone marrow necrosis, and the way you treat that is with plasma exchange. It's supportive therapy, and we've had some successes with that. We've had a couple of patients recently who have come in and been treated for fat embolism syndrome, and have done very well. But you do have to have a high index of suspicion, and it does have a very high mortality rate associated with it. Moving on to acute neurological complications. So 11% of young adults have had a stroke by the age of 20, 24% will have had one by the age of 45. and that may be ischemic strokes, and 10.8% of adults have aneurysms. So, you know, sickle cell patients are more at risk of stroke, ischemic and hemorrhagic. They're more at risk of meningitis because they're functionally hyposplenic. I remember a patient I had at Ealing who came in, he wasn't known to us, and he came in incredibly unwell, DIC, renal failure, he had bloodshot eyes, and he couldn't comprehend what I was saying, and it transpired that, you know, his bloodshot eyes were endophthalmitis. He couldn't hear because he'd become deaf, and basically he had pneumococcal meningitis. He did recover, and interestingly, he had the pneumovax vaccination, but the strain that the meningitis that he had was a different strain. Other neurological complications you can see are venous sinus thrombosis, seizures, and the other important neurological complication to remember is extradural and subdural hematomas in the absence of head trauma, and that's because the bones are more fragile, just because of skull bone infarction. So if someone comes in, obviously with you suspect, believe neurological complications to the stroke, you do an urgent CT brain if out of hours, but it may be negative in early stages of ischemic stroke. You then want to do an MRI and MRA, or contrast enhanced CT angiography, or MRV if you're worried about cerebral venous thrombosis suspected on clinical grounds, and then you do your routine blood tests, making sure you do a group and say cross-match, and then a lumbar puncture of signs of meningism to exclude infection or subarachnoid hemorrhage. Obviously checking the coagulation is normal first. And obviously rehydrate, regular monitoring of neurological status, refer to the on-call neurology SPR consultants or hyperacute stroke unit. So within the HCC for us, there's hyperacute stroke unit at Norfolk Park, there's one at Charing Cross, and there's one at St George's. You do arrange an urgent red cell exchange, and you want the sickle level to be less than 20%. Anticonvulsant therapy if those seizures occur. Obviously avoid or stop aspirin, NSAIDs, or low molecular weight heparin until hemorrhage is excluded. Long-term regular exchange transfusion program every 4 to 6 weeks to maintain a hemoglobin S level below 20 to 30%. An MRA may help you to determine the duration of the transfusion regimen, and the risk of recurrent neurological events is greatest in those with abnormal cerebral vasculature. If they don't have any occlusion or neurological deficit, you may want to monitor that further transfusion. If they do have occlusion of vessels and or neurological deficit, irregular transfusion for at least 36 months. And for a TIA, consider lifelong antiplatelet therapy if there's no contraindication, and then obviously neurology review. What about, I would say also that as patients with sickle cell are getting older, not all strokes will be related to their sickle. It may be related to other causes of stroke, just like the general population, such as hypertension, diabetes, atrial fibrillation.
Did they try to wake her up?
You know, there is limited data on the use of thrombolysis in sickle cell patients. So I'm going to read something from the standards because I never remember it. It said, may benefit from thrombolysis and red cell exchange. We need a sort of a careful collaboration between the neurologist and the haematologist, and obviously it depends on the patient age, genotype, phenotype, MRI findings, and traditional risk factors. And there was a study performed in 2017 which compared outcomes between 832 patients with sickle cell disease and 3,328 non-sickle cell disease controls, and there was no significant difference in the fraction receiving thrombolytic therapy on experiencing symptomatic intracranial hemorrhage. So it potentially is an option, but needs careful discussion between the haematologists and the neurologists. Priapism. So the lifetime incidence is 35 to 90% male patients with sickle cell. Majority occur before the age of 20. Can be stuttering or fulminant. The British Association of Urological Surgeons have put ischemic priapism into 3 categories, whether it's less than 48 hours, 8 to 72 hours, 48 to 72 hours, or more than 72 hours. So conservative management, gentle exercise, try to urinate, keep warm. Definitely do not put ice packs there. That's an absolute no-no. Active management, so penile aspiration if less than 48 hours to decompress the corpora cavernosum, and that does need to be done by a trained urologist. I always mention this story, but when I do this talk, but when I was a registrar, I won't say where, a very gung-ho A&E consultant thought it was fine for them to do it, and the patient developed a very nasty hematoma, which was more painful than the actual priapism. So yeah, it does need to be a trained urologist who does it. You can obviously injection of alpha-adrenergic agents, and if that fails, it can be considered for a shunt procedure. And and sometimes young patients have needed primary penile implants. Preventative strategies, so some can use alpha agonists or anti-androgens. And epinephrine is something that has been used as a preventative measure. And it's something to always ask about in clinic because people are often quite reluctant to be forthcoming. Osteomyelitis is often difficult to distinguish from a vaso-occlusive crisis. Salmonella, Staph aureus and other gram-negative bacilli are the most common organisms. And a plain X-ray is not usually helpful. Ultrasound changes where you can see subperiosteal fluid more than 4 millimeters, which might point you in the direction of it being an osteomyelitis. An MRI is really the best modality for monitoring response to treatment, and obviously it needs an MDT approach to management, and we use IV ceftriaxone and clindamycin for 6 weeks as a 6-week course. So anemia and sickle cell. So say you had a 35-year-old gentleman with sickle cell, he comes to A&E, he's feeling tired and his hemoglobin is only 40 grams per litre. So what would you be thinking of? What investigations would you perform? So either he's sickle related, either he's hemolyzing, or he's got bone marrow suppression and erythropoiesis due to an aplastic crisis, or he's developed a sequestration syndrome. So which viral infection is this? So that's the classic slap cheek appearance that you see in parvovirus infection. So it causes a transient red cell aplasia secondary to parvovirus. Sickle cell patients are more prone to it because their red cell survival is much shorter than the normal 120 days. So anyone with a hemolytic anemia is at risk of that. And how you pick it up is that they'd be anemic. And this is why the reticulocyte count is so important. The normal response, if you're very anemic, is your reticulocyte count will go up to make more red cells. But if in an aplastic crisis, you'll have a relative reticulocytopenia. So the level actually may be within the normal range, but for the degree of anemia, it's not adequate. It's mostly self-limiting. And after 1 to 2 weeks, the barrow begins to function normally, and you might need to give the patient a top-up transfusion. Which group of people should the patient avoid and why? Well, it's immunosuppressed patients, and pregnant nursing staff shouldn't look after the patient because of the theoretical risk of high drops. Any other family members with sickle cell disease also in the same should be monitored as well. Splenic sequestration, you don't tend to see in adults, you're more likely to see it in children. And actually, before sort of the antenatal screening and neonatal screening, Pen V prophylaxis, pneumococcal vaccines, the splenic sequestration and pneumococcal sepsis was actually what used to cause the majority of mortality in children, because the first time the parents realised that their child had sickle would be when the child was very unwell with a splenic sequestration. It does have a very high mortality associated with it, and patients can come in shock, and do full blood count, cross-match blood cultures, treatment of shock. And the key thing is you do emergency top-up transfusions in steps, aiming for the baseline hemoglobin. You don't want to overdo it and just pile a whole load of blood in, because as the spleen shrinks, that all has to go somewhere, and that may cause hyperviscosity, and you may end up having to venosect the child. Broad spectrum antibiotics, and the other thing it can be sometimes confused with, so parvovirus infection can sometimes do this as well, and that's where see the reticulocyte count's really important as well, because here in sequestration reticular count was very high, and the jaundice is prominent, and there's the splenomegaly is obviously prominent. You might think on discharge about hypertransfusion until the maximum reduction of the spleen size, and you would think about taking the spleen out if they have more than one episode. Hepatic sequestration is something that we can do see in adults, and is usually less severe. So other causes of anemia, so delayed hemolytic transfusion reactions are more common, and if any of you were at the very good talk last week by the transfusion clinical scientist, she explained very well why hemolytic transfusion reactions are more common. Sickle cell patients, 1, because they're transfused more, 2, because they have a different antigen profile on the surface of their cells compared to the majority of people who donate are probably a sort of a different ethnic group and have a different antigen profile, so you're more likely to develop antibodies. G6PD deficiency is very common in the Afro-Caribbean community and an Asian community, so that also may be a cause, but that has a very classical blood film picture. Malaria, and don't forget other things like blood loss. So not it won't always be related to sickle. It may be something else. So hyperhaemolysis is a serious and potentially life-threatening complication of red cell transfusion. It's described in pediatric and adult sickle cell patients, and it was first described in 1997, and it was characterized by the destruction of both donor and recipient red cells after transfusion of compatible blood, with a significant reduction in reticulocyte count. It's a development of a more severe anemia after transfusion than was present before. You get a marked reticular cytopenia, and subsequent transfusions may further exacerbate anemia, and it may become fatal. Some patients have allo or autoantibodies, however in others no alloantibodies are identified, and it can cause an exacerbation of the vaso-occlusive crisis. So this is a normal blood film, and this is someone who, this is actually the very first patient I ever saw with hyperhaemolysis as a registrar in 2007. She was transferred here from another hospital, and she developed hyperhaemolysis. She had an unplanned pregnancy, and she decided to continue with the pregnancy, and we had to manage her throughout her pregnancy. So it was a very tricky balance, sort of getting her through that, but we did. But that's a blood film, so obviously showing far fewer red cells, and these are sort of nucleated red cells. The exact mechanism is unclear, so various mechanism postulated, so transfusion suppression of erythropoiesis, bystander hemolysis, and hyperactive macrophages. And how can you make a distinction between a delayed hemolytic transfusion and hyperhemolysis? So so for a delayed hemolytic transfusion reaction, it's usually self-limiting. So once the antibody, is cleared, then it's self-limiting. Whereas in hyperhemolysis, it's protracted. In delayed hemolytic transfusion reaction, you're only destroying the transfused cells only. With hyperhemolysis, you're destroying both the transfused and autologous cells. You will develop a new antibody in a delayed hemolytic transfusion reaction. Then you may or you may not in hyperhemolysis. In a delayed hemolytic transfusion reaction, the direct Coombs test, which measures the antibodies on the surface of the red cells, will be strongly positive, whereas in hyperhemolysis it will either be negative or weakly positive. And the reticulocytes will be high in a delayed hemolytic transfusion reaction, where they'll be relatively low in hyperhemolysis. You may also see a high ferritin as well in hyperhemolysis. So how do you manage a hyperhemolysis? So you avoid transfusion if possible. If you do need to transfuse, which obviously we did with this woman who was pregnant. I mean, I remember walking into clinic and one day, and the hemoglobin was like 28 grams per litre. I was like, oh, we've got to give her some blood. But anyway, so you give IVIG, 1 gram per kilogram for 2 days. It's a methylprednisolone. You can give erythropoietin. And now there's second-line treatment that we can give if that doesn't work, which so eculizumab, which is a monoclonal antibody against C5, and it's used in another condition called paroxysmal nocturnal hemoglobinuria, also hemolytic uremic syndrome. And it's given once intravenously, and a second dose 7 days later if there's evidence of efficacy of treatment, but ongoing hemolysis. And then after that, no further doses or courses are permitted. Because it affects the complement pathway, they're at risk of meningitis, so you give them ciprofloxacin for 8 weeks from the last dose of eculizumab, and then you switch them back to the penicillin prophylaxis, and they should also be vaccinated against meningitis A, CWY, meningitis B. And third-line treatment, if that doesn't work, is rituximab, which is a monoclonal antibody against CD20, which is on the B cells. And NHS England have done an evidence review on the prevention and management of delayed hemolytic transfusion reactions and hyperhemolysis in patients of all ages with hemoglobinopathies. So if you do have a patient that you think needs eculizumab, then ideally you should convene an urgent HCC panel discussion, and then to see if the panel agrees, and then if they agree, it's on the blue tech forms. So once it's agreed, then you just have to fill in a blue tech form, and it's funded. And then retrospectively discuss it at the NHP so that they can collect data on patients that it's been used on. So other complications that you can have is like acute abdominal pain and jaundice. As I said earlier, sickle cell patients are more likely to have gallstones, and then all the complications related to gallstones, because it's a type of hemolytic anemia and they have bile gallstones. So they can get biliary colic, cholecystitis, cholangitis, pancreatitis. Just a little word about a mesenteric crisis, which sometimes called girdle syndrome, which is what you can see here, is where a sickle patient presents with abdominal pain, anorexia plus or minus vomiting, You know, they get abdominal distension, bowel sounds can be normal or reduced. And as you can see here, you can see distended bowel loops with fluid levels on an X-ray, and they can get hepatomegaly, and patients are at risk of going on to develop an acute chest syndrome. And how you manage that is regular IV fluids, analgesia, keeping the patient ill by mouth, an NG if the patient if vomiting, antibiotics, the usual Kefenmet for any abdominal situations, and early red cell exchange if they become hypoxic. And you need to measure the abdominal girth at the umbilicus 1 to 4 hourly, and measure the liver size twice a day. One last sort of complication to think about is Yersinia enterocolitis, especially if patients are receiving iron chelation and are significantly iron overloaded. Unfortunately, at the very beginning of COVID, when we weren't testing and 111 were telling everybody if you had a fever to stay at home, we had one of our sickle patients, unfortunately, who had a fever, was advised to stay at home, and then eventually did come in to hospital and was very unwell, was in renal failure and DIC, and she had gram-negative sepsis, so she was significantly iron overloaded. So it's a COVID-related mortality, but due to another cause. And that's all I have, and I'm very happy to take any questions.
Thank you, Mamta. If anyone can either put questions in the chat or they can ask Mamta questions directly. Yeah, in acute chest syndrome, would you consider top-up transfusions or a straight exchange?
Well, that's a very good question. Sometimes you can get away with just doing a top-up, but I think because it's so easily available to us, we usually just go straight for an exchange. And I would say it's Satirios, isn't it? He was asking the question at Hillian. I would always say, if you're in a district general, get the patient across to us. If you're worried that they may be developing a chest syndrome, because they can decompensate very quickly, and it's much better just to get them across. And then if we don't need to exchange them, we don't need to exchange them. But if they're there with you at the district general and you have to exchange them manually, it's not pleasant. I've done it before. It's not good. You're there all night.
A question from Shazia. Great talk. Is there a hemoglobin level under which you would transfuse in hyperhemolysis?
I think it depends on the situation, really. I don't know. I don't think I would be able to give a specific hemoglobin. I think if it's less than 50, 40, then you'd be like getting a bit. You'd want to. I think you'd want to transfuse with IVIG and methylpred cover, but it depends on their other parameters. I don't know what others feel of my colleagues.
I think we've gone down. We've gone down as low as 25.
Yeah, 25. I mean,
yeah.
So the pregnant lady.
That's, it's a danger. It's a very nerve-wracking situation, isn't it? But I think I mean, in the past we have gone down as low as that.
Yeah. And I remember the pregnant lady I was talking about. She came in with her hemoglobin was about 28. She just walked into clinic. I was quite amazed that she wasn't particularly symptomatic, but because she was pregnant, that was obviously a different scenario. And we did give her a few transfusions through pregnancy with IVIG and methylprednisolone cover, and she also had cyclosporin as well.
Yeah, Mamta, I would agree. I think my concern is always that if you do transfuse, then there is a risk that you may end up in a worse position than you started in, because they will hemolyze the only blood they got left. So yeah, it is very nerve-wracking, but you try and hold your nerve as long as you can.
You are very brave though to go to 26. I think we have a cutoff of around 40.
Yeah.
The next question from Sotiris is, thank you, Mamta. Also, are there any reservations for using EPO in hyperhaemolysis, as I expect you would increase the sickle cell population? I may be wrong. Well,
we do use it, but then I've heard from my paediatric colleagues when they had a case that they were advised from NHSBT, is it Nell, what's his name? Prof Wynne, not to use EPO, but I don't know the rationale for that. Do we know, Josu? Because we do use it and we've had no problems with using it.
Yes, we do use it also in the recovery period to try to avoid the situation returning. But it is true that the last time Nay Wynne said not to give it in the very early stages, and I don't know the reason for it.
Yeah, and I did ask the lady who did the talk last week, and she was going to check and get back to me. So Therese, when she does that, I'll let you know when I'm next at Hillingdon. Anything any of my other colleagues feel I have missed or think I should have included for the
just going back to the just going back to that question about the top up in acute chest syndrome. I mean, I think the principle in an acute chest syndrome is to try and lower the sickle percentage. So, I mean, you may be able to do that sometimes with a top up if the hemoglobin is low. But I think an exchange is always preferable. So where an exchange is available, I would always recommend a red cell exchange. If there's a delay in getting a red cell exchange while you're waiting to transfer the patient, or a red cell exchange is not possible, then a top up might be a temporary. It might be a solution. Sometimes a temporary kind of holding measure. But I would always normally recommend a red cell exchange.
Yeah, no, I agree. And so, Therese, as I said, you just pick up the phone, you call us, and that's what you need to do. And we would get the patient here as soon as we can.
Are there any other questions for Mamta? In that case, thank you so much for the talk today, Mamta. That's extremely good of you. And as previously stated, I'll make sure that the recording of the session is available from early next week, and I'll send out a link to all the people who are attending.